All right, good afternoon, everybody. My name is Jan Schoenberger. I had a nice introduction this morning from Rick Bucata, which I really appreciated. I'm very happy to be here, very excited to speak with all of you. I work at LA County, USC. I'm an emergency physician. I work with a great team of PAs and NPs, and so I'm very, very excited to be here to talk to you. We're going to spend the next 30 minutes before the break. We have a 15-minute break after this talk, talking about pregnancy and vaginal bleeding. We're not going to talk about, in this talk, we're not going to talk about emergency deliveries, so we're not going to do a lot of obstetrics in this talk. We're going to talk mostly about a very common chief complaint, which is vaginal bleeding. We'll talk a little bit about pregnancy. So first, let's talk about the sickest patient in this group, which is the patient who comes in with vaginal bleeding who is unstable. This is actually kind of a more unusual circumstance, but when it happens, you got to know what to do. And when you hear the words bleeding and unstable in the same phrase, the first thing you should think of is resuscitation. So you're going to start with, just like any other patient who's bleeding and unstable, 2 large bore IVs, type and cross, thinking about pre-op labs, this person might need a procedure, etc. When I say unstable, what I mean is someone who looks sick to you, or they have something objective in terms of instability, their blood pressure is low, or they're tachycardic. So next thing, so we've got our IVs in, we're going to send off our labs, we're going to transfuse. If they're losing red stuff, we're going to put red stuff back in if they're unstable. And then we have to do some other objective things. We have to figure out whether or not this is actually vaginal bleeding. Often patients see blood in the toilet or blood in their underpants, and they think it's vaginal bleeding, but sometimes it may be rectal bleeding. It could be GU bleeding. So you have to confirm where the source actually is. The next thing we need to know with any patient who's presenting with vaginal bleeding is whether or not they're pregnant. It's a huge question, and it comes right up front. It completely changes the differential diagnosis. So a rapid pregnancy test is in order, and a point-of-care test would be best, something that you can get back right away. The next part would be if you have access to an ultrasound machine. Ultrasound is such a big deal in emergency medicine now. If you have an ultrasound machine, there are a few other data points you can get. You can do a FAST scan, which is a focused assessment of sonography and trauma, which is looking for any free fluid in the abdomen. And you can take a look at the pregnancy if they happen to be pregnant. You can look for fetal heart tones. You can get a general idea of gestational age. Just getting more information can be helpful. And if you have an unstable patient who has vaginal bleeding, you're going to need a consultant. So calling your OB/GYN would be helpful. They're probably going to need a DNC or some kind of operative procedure. So there's the last one on that. The much more common scenario is the patient who presents with vaginal bleeding but is stable, not unstable, but stable. And this is a very common chief complaint. So some of the principles are the same. It's still a bleeding patient, so we're going to get IV access. We're going to need to know whether or not the patient is pregnant. A point-of-care test is best here as well. A type and screen, a CBC, getting some data points. And then we have to look at whether or not we're pregnant or non-pregnant and think about the differential diagnosis there. And again, making sure that it's actually a vaginal source where the blood is coming from. If the patient's not pregnant and is stable and having vaginal bleeding, we're going to talk about the differential for that. But we're probably going to do transfusion if the patient is very symptomatic in terms of the anemia. If they're complaining of shortness of breath or very tachycardic, we'll consider transfusing them. But in general, the management in terms of the non-pregnant patient with vaginal bleeding can be deferred for an outpatient type of treatment. We're going to talk, though, about some of the treatments that are on the menu there. And then if you have a stable patient with vaginal bleeding who's pregnant, you're going to order a quantitative HCG, you're going to order a type and screen, and you're going to consider ordering a formal ultrasound to look and evaluate the pregnancy. So let's spend a few minutes talking about the patient with vaginal bleeding who's not pregnant. Now, one of the things about emergency medicine is we learn to speak the language of our consultants, and so we have to learn the kinds of words that the gynecologist would use when they're describing a patient with vaginal bleeding, so there's some terms here to recognize. The first one is menorrhagia. Menorrhagia basically means that you're bleeding on a regular menstrual cycle, but you're bleeding very heavily or it's lasting a few days longer. That's menorrhagia. That is opposed to metrorrhagia, which is basically irregular bleeding, sort of off cycle. These two words, menorrhagia and metrorrhagia, are kind of similar, and I always have a hard time remembering which one is which, and this is how I remember it. Metrorrhagia, I think of the metro, like a metro train, the subway going along and stopping irregularly, and so that's how I remember that metrorrhagia means irregular bleeding versus menorrhagia is heavy bleeding. And menometrorrhagia is just a combination of the two. It's heavy and it's irregular, it's both. Now, there's another category, which is if you see a patient who is postmenopausal presenting with vaginal bleeding, it brings up another set of worries, right? It brings up another set of worries like cancer. So there's another set of differential diagnoses that come into play if the patient is actually postmenopausal and presenting with vaginal bleeding. Now, more on non-pregnant vaginal bleeding. If they're premenopausal, of reproductive age, there's a few things on the differential there. We've got fibroid uterus, we've got dysfunctional uterine bleeding, which we're going to talk about in the next slide, endometriosis. It could be trauma, could be sexual trauma, could be a foreign body, and there are some medical causes that can cause excessive vaginal bleeding, things like hypothyroidism, things like coagulation disorders. And then we talked a little bit about postmenopausal causes. Many of those will also be true, but we also add cancer to the list, and specifically endometrial cancer. These patients who are stable with vaginal bleeding rarely need any kind of an emergent intervention. They've usually bled down over time. They're usually stable appearing. They rarely need an emergent intervention in the emergency room. Transfusion maybe if they're symptomatically anemic. But you can usually refer these to the gynecologist for definitive evaluation and treatment. Now, what is dysfunctional uterine bleeding? What does that term mean? It's kind of a very general term. And basically what it means is that if you have abnormal uterine bleeding, but you can't figure out any of the other things, there's no trauma, there's no endometriosis, there's not a fibroid, there's no organic disease, we kind of call it dysfunctional uterine bleeding. And these are usually hormone-related conditions. This is actually the most common cause of abnormal vaginal bleeding during the reproductive years. Now, when you're asking about the history in these patients, you want to ask them about what's happening now compared to what's normal for you, because we all have different normal menstrual cycles, and so what is it that's different? Is it heavier? Is it more days? What's normal for you? That's important. And other things you want to ask about are also symptomatic anemia questions. Are you getting short of breath? Are you dizzy, etc.? If they have other medical conditions like diabetes, thyroid disease, other endocrine problems, whether or not there's liver disease that could lead to a decrease in production of coagulation factors, if they've had a recent illness, or maybe there's a medication on board that's contributing to the bleeding. Now, you have to also think about occult bleeding disorders, things like von Willebrand's disease, which is an inherited coagulation disorder. It's an inherited problem with platelet function. It's a pretty common disorder. Those patients generally, though, will have a history of menorrhagia since they started their menarche. They may have a family history of a bleeding disorder. They may also tell you about some easy bruising or bleeding with brushing their teeth, things like that. If they've got epistaxis that lasts abnormally long. Those would all be clues to someone who has an inherited platelet problem. That may clue you into that. And testing in these patients, we've talked about pregnancy testing, CBC, they need coagulation studies, and you may consider doing a pelvic ultrasound. Not totally necessary in these patients that are stable, vaginal bleeding, non-pregnant. Don't have to do an ultrasound, but an ultrasound can be diagnostic for things like fibroids or thickened endometrial lining, etc. Now, how do we treat these patients? Well, as I mentioned before, most of this can be referred to a gynecologist, but just so you know what the treatment generally is, and if they do recommend something to you, we often start them on oral contraceptives. It's mostly hormonal management. Oral contraceptives would be the most common treatment to reach for, but there is also IV estrogen that can be given. You could also use a progesterone. This often is used in patients who have anovulatory bleeding because they have unopposed estrogen. And another thing to recommend would be NSAIDs. NSAIDs actually decrease blood loss in vaginal bleeding. How does it do it? It does it by the prostaglandin inhibition and thromboxane. It causes vasoconstriction and a little bit more extra platelet stickiness. So it can actually reduce the blood loss. And then there's other things on the menu, but you want to talk to your GYN about that in terms of recommending treatment. So let's transition from the non-pregnant vaginal bleeder to some tidbits about pregnancy. So first off, when we're talking about beta HCGs in general, HCG doubles about every 48 hours in early pregnancy. That helps give you sort of a prediction as to where the HCG should be in the next couple days. A couple other anatomic things to know. The uterus becomes palpable at over about 12 weeks. It starts to pass the pelvic brim. So you can start to palpate the uterus on an abdominal exam just about 12 weeks and beyond. By about 20 weeks, it reaches the umbilicus. And that's an important number to know because we consider pregnancies to be viable just at about 20 weeks and a little bit beyond. So you can pretty quickly, on a quick abdominal exam, decide whether or not this may be a viable pregnancy because it should be right at the umbilicus at about 20 weeks. Now, about 1 in 100 women of childbearing age is pregnant at any given time. We always teach our residents the mantra of just test them all. You know, age 8 to 80, everybody gets a pregnancy test. Any female with abdominal pain, vaginal bleeding gets a pregnancy test. You just never know. It's amazing how many pregnancies seem to happen out there without anyone knowing about them. So you go ahead and just test people. Regardless of what she tells you, go ahead and test. It's cheap, it's important, go ahead and test them. Now, what about patients who come in with vaginal bleeding? You do the pregnancy test and it's positive, okay? Our differential has changed. What could be going on? Well, the biggest concern in that scenario is ectopic pregnancy. That's the highest risk diagnosis in that particular moment. So if you are faced with that scenario, the positive pregnancy test and vaginal bleeding or abdominal pain, you may consider consulting with the physician. Now, the more common things that happen with patients who are pregnant and first trimester vaginal bleeding are things like threatened abortion or threatened miscarriage. This is where a patient has bleeding. She may or may not have some pain. She hasn't really passed any tissue. It's an early pregnancy. And on your speculum exam, the cervix is closed. It's a closed os. But on an ultrasound, she has an intrauterine pregnancy. So you've got an intrauterine pregnancy, but you also have bleeding. That's called a threatened abortion because the os is closed, the cervix os is closed. So it's just threatened. We don't know where this is going. And what we recommend for that is just pelvic rest. There's not much we can do. Nature's got to take its course, see what happens, normal activity. Now, there's another category, which is called inevitable abortion. This is where the patient has bleeding, may have pain, but on your speculum exam, the os is open, the cervical os is open. That means this is going to be an inevitable AB. There may or may not be passage of tissue yet. On an ultrasound, there may be products of conception that can be seen, but because the cervical os is open, that's why it's called inevitable. You can consult your OBGYN. This may be observed or may go straight to a DNC. There's a couple other categories here in our first trimester bleeding. One is incomplete abortion, which is when a patient has vaginal bleeding, pain, also an open os, but on ultrasound has retained products, isn't passing the products. And those usually need a DNC to remove the products of conception. And the last category is complete abortion, which is bleeding and pain. The process is over, the cervical os has closed, and on an ultrasound, the uterus is empty. Now, you can really only call this a complete abortion if you're sure that there was an IUP on ultrasound before. Because what you're faced with in this particular scenario is a patient with a positive pregnancy test who's bleeding, and you don't see an intrauterine pregnancy on your ultrasound. So that could also be an ectopic until proven otherwise. So if you know that she had an IUP on ultrasound before, then that would be a complete abortion. Now, there's charts like this that you can look up on the internet. You don't need to memorize these kinds of things. But we said that HCG doubles every 48 hours in early pregnancy. So it's pretty predictable what the HCG level would be as you go through the first few weeks of pregnancy. This corresponds to what you would expect to see on ultrasound when you're looking for a pregnancy on ultrasound. So in terms of early pregnancy, we first look transvaginally with an ultrasound. And we should see a pregnancy on transvaginal ultrasound at about 5 to 6 weeks. This corresponds to an HCG level of about 1,000 to 2,000. Let's call it 1,500. So if you see an HCG level of 1,500, you should be able to see a pregnancy on transvaginal ultrasound. Now, it takes a little longer to see pregnancy on transabdominal ultrasound, more like 6 to 7 weeks, and your HCG level goes up a little bit higher in terms of your threshold to see a pregnancy on transabdominal ultrasound. So that's an HCG of about 6,000 to 7,000. And what do we call an actual positive intrauterine pregnancy? Well, there's a specific definition. It has to have a gestational sac, plus it has to have a yolk sac, which are ultrasound findings that tell you that this is an actual intrauterine pregnancy. It looks something like this. This is an image of an intrauterine pregnancy. You see the black area, which is the gestational sac. That starts forming at about 4 weeks. And then you see that yolk sac. It's that little ring that has sort of a bright area to it. That comes around 5 weeks. And then the fetal pole, which is a small mass of little fetal cells, comes around 6 weeks. And the area surrounding that on this picture is the uterus. And so this is what an intrauterine pregnancy would be. This would be a positive IUP. You have to have all these elements to call it an IUP. Now, ectopic pregnancy. This is someone that we have to think about in early pregnancy, positive pregnancy test, vaginal bleeding, may not even have vaginal bleeding, could just have abdominal pain, but a positive pregnancy test. And when we see those combination of things, we've got to be looking for that pregnancy. Now, ectopic pregnancy is sometimes called tubal pregnancy. It's when the fetus doesn't implant normally in the uterus. It may implant in the fallopian tube. It may implant in the ovary. This occurs in 1 in 50 pregnancies in the United States. There are risk factors for ectopic pregnancy, things like history of STDs with tube scarring, things like that, previous ectopic pregnancy. But there are patients who are going to have this that have no known risk factors. Now, these usually, the natural history of an ectopic pregnancy is these often go on to rupture if they're not diagnosed, and they'll rupture at about 6 to 8 weeks. But a lot of the patients that have this have symptoms before the rupture, so it's our job to try to pick this up. This is a high-risk diagnosis that we're looking for. They may have pain, they may have bleeding, they may have both, they may just have one or the other. So, in looking for an ectopic pregnancy, what are some of the essential elements of our workup? Well, we need a quantitative beta, we need a type and screen, we need a CBC, and we're going to need to order an ultrasound to go looking for that pregnancy. And we have to look at that quantitative HCG and know a little bit about when we should be seeing the IUP on the ultrasound, which is why we went over the numbers before. So remember, with transvaginal ultrasound, the number is about 1,500. You should be seeing a pregnancy at about 5 to 6 weeks on transvaginal ultrasound. And that's called the discriminatory zone. Now, when it comes to looking at ultrasounds and ectopic pregnancy, there's a variety of things that can be seen on the ultrasound. You can actually see the pregnancy in the ovary or in the tube sometimes, or sometimes it's just going to be an empty uterus. There's a variety of different things to look for. If you do see an adnexal mass with a fetal heart rate, that's pretty diagnostic. You don't always see that. Sometimes it's just the empty uterus and you've got a positive pregnancy test, so you've got to put those things together. These are some different ultrasound images of what an ectopic pregnancy might look like on ultrasound. You could see an empty uterus and free fluid, as is shown there. You might see an actual structure in the adnexa or the tube, but the ultrasound can often show you the ectopic. Now, if you have a patient, okay, so she's got an HCG that's below 1,500, the ultrasound is inconclusive, it's not diagnostic for an ectopic, what do I do with that patient? Well, that patient can go home if they're stable, but they've got to come back for another beta check, because we know that the beta HCG is going to double every 48 hours. So if it's a normal pregnancy, it should follow those standard rules. Ectopics don't have normal beta production. So they can go home and they need follow-up for a beta check, essentially. And you have to give them very good discharge precautions to make sure they come back if things are getting worse. If they're unstable or very, very symptomatic in terms of pain, then those patients need to come in or be observed. You got to talk to your consultant. In terms of the treatment, how do we treat these ectopics when we find them? Well, there's a couple different routes. There's a medical arm and a surgical arm. You can treat these medically without surgery. You can treat them with methotrexate. But there's a specific list of criteria that the patient has to fulfill to get methotrexate. It has to be early. They have to have the ability to follow up. They have to have the ability to be able to come back, because there are going to be some methotrexate failures. But there is a medical option. And then some people are going to have to go for surgery. If it's a late ectopic, if they're having a lot of pain, if they can't follow up, that's someone who would go for a laparoscopic type surgery. So medical and surgical arms to treat the ectopic. Now here's a pretty extensive algorithm that kind of reviews all the things we just talked about, how we're going to start with our ultrasound. We've got to think about our HCG, combine that information to make some decisions. And so I'm not going to go through all the steps of that, but that's a good review, kind of going right back over what we just talked about. Now, let's go on to some other pregnancy-related conditions to talk about. The first one is placental abruption, or abruptio placenta, it's called sometimes too. This is a cause of late pregnancy abdominal pain and or vaginal bleeding. This is where the placenta starts to tear away from the wall of the uterus and can be definitely pregnancy threatening. So the placenta tears away. Now this can happen spontaneously, or more commonly it's related to some kind of trauma. And it could be even minor trauma, just a little fall down the stairs. It could be major trauma. But we always worry about abruption of the placenta with any kind of trauma in a late-term pregnancy. Now, the patient may or may not have vaginal bleeding. The characteristic description of the vaginal bleeding is that this is painful bleeding, it's associated with pain, and it's often dark red bleeding. They don't always present like that. Sometimes they don't have any vaginal bleeding, but that's the kind of textbook description of abruptio placenta. The other trick about abruption is that ultrasound is not sensitive enough to make the diagnosis of abruption. It's unfortunate. You wish you could just order the ultrasound. The ultrasound tells you the pregnancy is okay and you'd be done with it, but it's not sensitive enough. What you have to do to diagnose abruption is actually monitor the fetus, because the fetal heart rate will start to change as the placenta is tearing away from the uterus. The vascular supply that's going to the fetus will affect the fetal heart rate. So you'll see fetal bradycardia and loss of variability and a bunch of other things in the heart tracing, and that's going to help you pick up abruption, because ultrasound is not perfect. You're still going to order the ultrasound, but if it doesn't detect it, it could still be there. It's not perfect, unfortunately. Sometimes this can be confused with preterm labor because the patient has a lot of pain and could have vaginal bleeding, but in fact it's abruption. So these patients, if you suspect abruption or think it might be happening, you have to admit them to L&D for fetal monitoring, and they have to watch the fetal heart rate. This is what placental abruption looks like on ultrasound. You can see the placenta tearing away from the uterus and causing some hemorrhage behind it. And as you see in the illustration, that bleeding, depending on where it lies in the uterus, can be concealed. So that patient with that placental in the illustration wouldn't have any vaginal bleeding. You wouldn't see any vaginal bleeding. You may just have abdominal pain. And you can imagine that at that little pocket of blood laid behind the fetus, the ultrasound may not be able to see it. And that's why it can be concealed, and the ultrasound may not be good enough to pick it up. And in fact, the fetal heart tracing is the thing that actually can diagnose that there's a problem. Now, placental abruption, which is a cause of bleeding in late-term pregnancy, has to be sort of compared to placenta previa, which is another thing to think about in later-term pregnancy, second, third trimester with vaginal bleeding. Placenta previa is where the placenta implants over the cervical os, and so you get bleeding from that. And that bleeding is typically described as painless bleeding, no abdominal pain, and bright red blood. So that's compared to the placental abruption, that it's classically described as bright red and painless, as opposed to the painful dark red kind. Now, because of placenta previa, because of the possibility of this, a patient who's in the second or third trimester who presents with vaginal bleeding, we don't do any vaginal exams on those patients because we don't know at that point if it's placenta previa or not. So a vaginal exam is contraindicated in a patient in second or third trimester who's having vaginal bleeding, because if the placenta happens to be right there, we don't want to disrupt it. And it turns out that in this diagnosis, ultrasound's very accurate, because the ultrasound can actually see that placenta lying over the cervical os. So the ultrasound can help us with this one. Here are some illustrations to show us what placenta previa looks like. You see the normal placenta, and then you see the placenta previa. As the placenta is kind of crawling down towards the cervical opening, you can have a marginal placenta previa or a complete placenta previa. Sometimes you'll see in early pregnancy, when you order an ultrasound on a pregnant female, that it mentions placenta previa in the report. But it turns out that sometimes the placenta will move as pregnancy goes along. So this is what we're talking about in later pregnancy in second and third trimester as a possible source of bleeding. And this is what it looks like on ultrasound. Here's another illustration just showing you placenta abruption versus placenta previa. So you see the normal placenta there in the uterus, and then you see the abruption as the placenta tears away from the uterine wall. There's a little bit of blood, and then you see where the placenta previa is with the placenta down low, okay? All right, and the last couple topics here. One is preeclampsia. This is another emergency that happens in second and third trimester of pregnancy. We see this in pregnant women who are generally over 20 weeks, so again, second and third trimester. This is a condition we don't really understand what causes preeclampsia. There's a lot of theories as to what causes this problem. There's some theories about vascular endothelial factors, et cetera, but no one really knows what causes preeclampsia. But what it is hypertension. Patients present with hypertension, and they present with proteinuria, so protein on their urine dip, and they may have a constellation of sort of vague symptoms. It could be a headache. It could be visual changes. It could be some swelling. It could be some abdominal pain. All of these things in combination with the objective signs of hypertension and proteinuria should lead you to think about preeclampsia, which is a very serious diagnosis and really only goes away when delivery happens. So it's an important diagnosis to pick up on. Preeclampsia is more common in patients with their first pregnancy. So in primips, patients who have multiple gestations, so twins, et cetera, or molar pregnancies, abnormal pregnancies, more common to see preeclampsia in those conditions. When we're talking about hypertension here, we're not necessarily talking about just the strict 140/90 that we're all familiar with in normal adults. For a pregnant woman, it really is relative to what her baseline blood pressure is. So if the systolic is 20 or more over, or the diastolic is elevated, that could also be indicative of preeclampsia. So you're going to dip that urine for check for protein, may or may not have edema, and if you think you have a case of preeclampsia, you got to call the obstetrician. These patients need to go on bed rest, they need to have blood pressure management, and they're going to probably have an early delivery. So it's a pretty serious diagnosis. When you have preeclampsia and then you superimpose on top of that a seizure, that's called eclampsia. And this happens in later pregnancy. So a late-term pregnancy patient that presents with seizure, which you can imagine is a pretty scary combination, this is eclampsia. The thing about eclampsia that people sometimes forget about is that eclampsia can happen postpartum too. So she may not even be pregnant in front of you. It could be a patient who's postpartum coming in with a first-time seizure, can still be eclampsia. So 4 to 6 weeks postpartum, someone comes in with the first seizure, you got to think about eclampsia, even though they're not pregnant at that particular moment. The vascular changes, the theory about eclampsia and preeclampsia, it's still valid there. Patients can present with headache, visual changes, hyperreflexia. And the thing about eclampsia is that we're going to treat that seizure much differently than we treat the regular old garden variety of seizure that we see in the emergency department. So instead of reaching for the benzodiazepines, in this case, we're reaching for magnesium sulfate. And not just the 2 grams that we give for lots of other things, we're reaching for 4 to 6 to 8 grams of magnesium sulfate, so big doses of mag to treat the seizures associated with eclampsia. In terms of managing their hypertension, there are a couple different drugs of choice. Hydralazine, which is kind of an old school drug we use in pregnancy-related hypertension, and labetalol are kind of the 2 favorites to reach for in terms of managing hypertension. And just like with preeclampsia, the definitive treatment for this is delivery. Once the fetus is out, it's going to stop. So that's the treatment for eclampsia. A couple other things to mention. HELP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets, is associated with preeclampsia. It's sort of a variant. You can see this in patients who are multigravidas, and they may present with epigastric or right upper quadrant pain as part of their presentation because of the liver involvement. So it's a variant of preeclampsia. It's still in the same family, but HELP syndrome's on there too, which means that you're going to have to send your liver enzymes when you're working these patients up and looking at their platelets, looking for hemolysis, so sending something like an LDH, et cetera, would be part of the workup. And you treat it just like preeclampsia. And then there's the PUPPP, which is what this picture is showing you, which is pruritic urticarial papules and plaques of pregnancy, which is this kind of weird rash that happens in pregnant women. It tends to start sometimes around stretch marks. It's thought to be caused by skin distension that you get this sort of nonspecific rash of pregnancy. And it can be treated with emollients and topical steroids and soothing baths, and it will go away once the delivery has happened. So that's a little picture of PUPPP, if you've ever seen that. The last topic is to mention RH sensitization, which is a problem that we encounter and should be thinking about in women who are RH negative. So here's how it works. You have a man, he's RH positive. His blood type is RH positive. So he's A positive, B positive, whatever. He's RH positive. Mom is RH negative. Mom is RH negative. Much more uncommon to be RH negative, but she's RH negative. The baby that she's going to have is RH positive. And this creates a problem because she's RH negative, but the baby is RH positive. There's an incompatibility there. And so what happens is that if mom, who's RH negative, becomes exposed to those little fetal red blood cells that are RH positive, she can develop antibodies to that RH positive. And that's not a good thing. The first pregnancy, it won't be a problem. But in subsequent pregnancies, if she gets pregnant again with an RH positive baby, she's now got antibodies to the red blood cells of that fetus. And that's a problem because it can cause hemolysis. And so the complication here that we're really worried about is what's called erythroblastosis fetalis of pregnancy, or hydrops fetalis. It's a bad outcome. So we want to prevent that. How do we prevent that? How do we deal with that? Well, it's with RhoGAM. So basically, we can use these antibodies to prevent the sensitization. So it prevents the Rh negative mother from developing those antibodies. It's used prophylactically in women who are Rh negative who are going to deliver. They get RhoGAM anyway. But in the emergency department, if we see a woman who's had an ectopic or an abortion or has had any kind of trauma, and we think there could be any chance that those little Rh positive fetal red blood cells have leaked out, RhoGAM is what's going to prevent this sensitization from happening. So there's dosing there. You can always look that up. There's a mini dose for early pregnancy, a bigger dose for later pregnancy, and RhoGAM will help solve that problem. Okay, thank you. We're out of time. Enjoy your break.